Very good morning, everybody. So today's lecture is on myofunctional appliances. So to start with, there are various types of appliances which are used in orthodontics. There are few which are used to move the teeth, which are the removable ones, the ones that you're making, your wire bending in the preclinical with the acrylic plate, which will move the teeth. The other type which is used to move the teeth is your braces, that is your fixed mechanotherapy. Apart from appliances moving the teeth, we have appliances moving or redirecting the bone also. So if you want to move the bone or redirect the jaw growth, then you have further two types of appliances. One is your myofunctional appliances, which are going to modulate the function of your muscles and improve the function and hence redirect the growth of your jaws. The second type is your orthopedic appliances, which will apply heavy force onto your bones and hence mostly inhibit your growth of the jaws. So this particular lecture is on myofunctional appliances, where we are just going to modulate and improve the function of the muscles and improve the function and redirect the growth of your jaw bones. So what is the need of you giving a functional appliance to any patient? There can be various reasons for it. Of course, if there is any skeletal problem, that means it can be a class 3 or a class 2. So any imbalance in skeletal jaw bases and you want to redirect the jaw base. So you give a myofunctional appliance. Or it can be a redirection of jaw base required in any direction, need not be just sagittal. So it can be a vertical increased maxillary growth. As you can see in this picture, there is increased gumminess seen, which is denoting that there is a maxillary vertical excess in this patient. Thus, this patient needs a redirection of the maxillary growth. Or it can be any muscular habit which needs to be retrained. Like here you have a lower lip trap, a hyperactive mentalis activity. So for this also it is your myofunctional appliances which will be given. So all these are not aiming for your dental movement. It is to redirect your muscles and influence your jaws in turn. Sometimes you see a girl growing very normally and maybe she had some skeletal problem. You corrected the jaw bone. However, with growth, you see that the mandible still continued to grow in an abnormal direction and continued growing forward. And patient turns out to become a class 3 following the treatment is over. So the lesson we need to learn is sometimes if you are suspecting any skeletal problem in any of the patient, you need to give a myofunctional appliance as your retention appliance to retain the results you have achieved. So now, before we screen a case for a myofunctional appliance treatment, we screen it by testing a VTO, that means visual treatment objective, where we visually try to see whether our myofunctional appliance will be a success or not. Clinically, what you do is, suppose it is a class 2 patient where your maxilla is in front, mandible is behind. You make the patient bite in a forward position, that means bring the mandible in front, and you try to assume whether the patient's profile improved or not. If patient profile improves upon bringing the mandible in front, that means yes, the class 2 is because of a retrognathic mandible. And you need to give a myofunctional appliance to improve the mandibular growth. Hence, this clinical VTO helps you to find out the etiology and plan an appropriate myofunctional appliance. That means whether it is the mandible at fault, whether it is the maxilla at fault, and then we treat accordingly. Now, this one is an advanced 3D VTO where you can actually use a software and check what is at fault in the patient and what has to be done. So if it's a growing patient, you plan a myofunctional appliance, or for that matter an orthopedic appliance for its correction. And if it is a non-growing patient, then you plan an appropriate surgery. So this 3D VTO will help you find out what is the etiology of patient's skeletal problem. So I'll show you a small video. So in this video, you have the picture and you can move the maxilla and mandible in the appropriate direction, and then yourself you can check whether the profile is improving according to you or whether it is worsening. So if it is improving, we say it is a positive VTO. If it is worsening, we say it's a negative VTO, and if it is somewhere in between, then you say not decidable. Okay, so here if you see in this picture, it is showing what skeletal, if you move the maxilla in front, how will the face finally look. Okay, if you bring the mandible in front, how will the soft tissue and the face finally look. So you have to plan and see whether the patient's face is actually improving when we are moving the maxilla mandible together in this way, or so you can actually see how the soft tissue will change accordingly. So if you feel both maxilla mandible moving together forward is what is making the patient look better, then you plan an appropriate myofunctional appliance to redirect the jaw growth in that direction. Or if it is a non-growing patient, then you are going to plan an appropriate surgery. So this one is where you're just planning that if I just take the chin in front, will the patient look good? So that cutting the chin is basically your genioplasty surgery. So rather than moving the entire jaw, if I just cut the chin and I bring it in front, will the profile improve? So this one we are moving the maxilla mandible together. You can actually turn the entire face, see from profile, frontal view, and check whether the patient's profile is improving or not improving with the same. So that's mostly we are using a clinical video, but in advanced clinics, you can actually go ahead with this 3D video, which will also help you motivate the patient. You can show the patient that after you wear this appliance, you will look like this, so your profile will improve. So you'll be able to get patient cooperation by motivating the patient in a better way. So the first thing that we do is when we plan that yes, the VTO is positive and I want to give a myofunctional appliance to this patient, I record a construction bite. So that's how the patient is biting. There is an increased overjet, a class 2 molar relationship, and I have decided that on biting in a forward position, the patient's profile is improving. There is a positive VTO. So the mandible is retrognathic, and I want to advance the mandible by giving a myofunctional appliance. So I make the patient practice and bite in a forward position, and I record this forward biting position with a wax kept in between. Then I retain this wax and I articulate my upper and lower maxillary cast in this position, the position I want the patient should have after the appliance treatment, a perfect class 1. Okay, and I fabricate an appliance in this position and I give it to the patient. So the patient will be forced to bite in this position instead of this with the appliance on. So this one is again a small video. These are the patient casts. So I'm just going to show you on the cast how we record the construction bite. You see there is increased overjet there. The molar relationship is also class 2 bilaterally. So I plan that we are going to give a myofunctional appliance to this patient. So we actually do it on the patient directly, but this one is we recorded the construction bite. We made the patient bite in a forward position with class 1 molar relationship and almost class 1 edge to edge incisor relationship, and we articulate in this position now, and we are going to make the appliance in this position itself. So we are going to force the patient to bite in this forward position always, and hence make the mandible grow in a forward position. This is according to your functional matrix theory. So we alter the functional mandible, forcefully make the patient bite in a forward position repeatedly, and then we can discard this bite and just make the appliance and give it to the patient. So with time, your condyle, bone, everything will adapt since the patient is growing. Okay, remember we are giving this in growing patients. If it is a skeletal problem in non-growing patients, then the only option will be a surgical line of treatment. Okay, so here whichever appliance we have chosen, we are making the required wire components which will be required, plan the design, and then make the appliance with this construction bite on. So there are various types of functional appliances which we can give. They can be removable, fixed, and there are further categories of each. So I'll give you a video of each so that you get an idea what comes in each category. So there is something which is called as group 1 appliances. Group 1 appliances are those Okay, I apologize for the inconvenience. So group 1 appliances will be the ones, like this one is a anterior crossbite. The upper tooth is palatally placed in relation to the lower tooth there. So to correct it, I give a lower inclined plane. This can be categorized as a type of myofunctional appliance. That means this group 1 is an appliance which is acting directly on the tooth, and it is actually not going to grow your bones, but yes, it has saved your maxilla. So it is going to redirect your maxillary growth indirectly. Otherwise, if this tooth would have continued to stay in a crossbite, then your mandibular teeth would have inhibited the maxillary growth. It would have let the entire maxilla come inside. Okay, and it is directly acting on the tooth, and it is going to correct your crossbite, and then your maxilla will be free to grow in its direction. Your group 2 appliances will be those which will help to redirect your jaw growth. That means redirect your growth of the mandible in this case. So this is also a type of myofunctional appliance. If you see carefully, in a class 2 patient, I'm giving it, and I am gliding the patient and forcing the patient to bite forward in a class 1 molar relationship. Okay, and it is touching the teeth. This acrylic part is touching the teeth. So it's a tooth-borne myofunctional appliance which is actually touching the teeth, but it is not moving the teeth, it is moving the jaw bone. Then you have a group 3 appliance, which is also a myofunctional appliance, which will again redirect your jaw bone, but it will not touch the tooth anywhere. So it is a tissue-borne myofunctional appliance. If you see, I give this appliance, it is not touching the teeth anywhere, and it is keeping your lower lip away from the mandible. Hence, the restraining effect of the lower lip has been kept away from the mandible, and mandible is free to express its growth. And there is a restraining maxillary labial pore to restrict the growth of the maxilla. And hence, your class 2 patient becomes a class 1 patient. So the same one, as I told you, tooth-borne and tissue-borne. So Prophet has actually made it very clear, and he says the first type is passive tooth-borne appliances. That means those appliances which are tooth-borne, that means sitting on the teeth, but they are passive. Passive means they're sitting on the teeth, but they're passive to the tooth. They will not be moving the tooth, they will be moving the jaw bones. Okay. But there are something which is called as active tooth-borne appliances also. That means they will be sitting on the teeth, redirecting the jawbone also, but they will also be actively moving the teeth. So they will have some active component also incorporated, which will be moving the teeth. So if you look at this video, this is actually a twin block appliance. That's why it's in twin. There are two pairs, and you have an expansion screw which is attached in the maxilla. So that expansion screw is going to cause an active tooth movement as well. Apart from, if you see the incline between the upper and lower blocks, it is also making the mandible bite in a forward position. So we are correcting the jaw bones, but also there is an active expansion screw appliance incorporated in this myofunctional appliance. So it's an active tooth-borne sitting on the teeth myofunctional appliance, growing the jawbone. This is the trimming of the acrylic we are doing, that we do towards the end of the treatment to settle the occlusion once our patient from class 2 has become class 1. Okay, so the last one is again your tissue-borne appliance. So this one is called your Frankel appliance. So if you see carefully, none of the components are sitting on the teeth. Acrylic is not touching the teeth. Acrylic is in the vestibule. So you have your lip pads, you have your buccal shield. So it's a completely tissue-borne myofunctional appliance, which again is being used to redirect the growth of your jaw bones. Then of course you have removable and fixed. Removable as in those which can be removed by the patient himself, and fixed will be removed by the doctor only. Then you have your fixed functional appliances are also further categorized into three types depending upon the material, the type of material which is used. We have flexible, rigid, and hybrid. So the flexible ones will be which are little flexible, they are fixed. So you can actually do it with your braces treatment happening. So they are fixed and you cannot remove it yourself, but the material used is very flexible. It's like a spring which is there in a nylon, a rubber like material. So this is how we are deciding the length in detail. There'll be a lecture later. I just want you to have an overview of what it means. So we are just deciding what should be the length of the spring because we want to advance the mandible. It is end-onish molar relationship and I want it to become class 1. So we are measuring the advancement and accordingly I am going to decide the length of the spring I will use. So that's the spring you can see on the other side already, and this is the other side. So we fix it on both the sides, we hook it on, and there is a ball there in the canine region. We are going to bend it so that it does not go and come out of the wire. I'm attaching it on the wire, and on the other side on the maxillary molar tube we insert, and then we are going to cinch. We are going to bend the wire so that it doesn't come out. Yes, so if you see it's very flexible, the appliance. It's very easy and convenient for the patient to wear it, and we don't need the compliance of the patient here because patient cannot remove it, right? So these are the latest appliances. Then we have a rigid one also, which is little rigid. Yeah, so this one is also a fixed appliance. Again, I'm giving it in a class 2 patient. So these are the bands, molar bands. I can put it in the mandible. I am going to put GIC around the molar band and cement them. So it is fixed. So you have a screw and a piston. You tighten it with a screw here, and it's a very rigid, crude way, and you're forcing the patient to bite in a forward position. So this is a rigid, fixed, functional appliance. Okay, then you have something which is in between of both of these, which is called hybrid. So it's a forces fatigue resistant appliance. So again, a fixed appliance. So I'm planning how much should be the length of my appliance depending upon the overjet. So I'm giving it along with my braces treatment. Okay, so you have a spring inside, but otherwise the other component is very rigid. Half of the component is rigid and half is a spring. So it's somewhere in between of the previous two that we saw. So it's rightly termed as the hybrid appliance. The way it is attached will be the same, one component on the upper, one in the lower, and the function is going to be that it has to forcefully make the mandible bite in a forward position. Okay, so that's how it will convert your class 2 patient into a class 1 patient. Okay, so there have been various advancements as you can see in your functional appliance therapy. So it actually started with jumping of the bite. So jumping of the bite actually was invented by Pierre Robin. You've heard about this syndrome, right? So it has got the problem of glossoptosis, retrognathia, where your mandible is behind and the tongue is big, and there are chances of airway obstruction because of a large tongue obstructing the airway because your mandible is behind. Remember, your tongue is resting in the mandible. So for such patients, it was thought that there should be something which can keep the tongue in a forward position always, which will save their airways from getting obstructed. So for that purpose, a monoblock was invented, which looked like this. Later on, they realized that this monoblock, rather than just keeping the mandible in a forward position to save the airway, if given in growing individuals, it was actually able to grow the mandible itself and make the mandible come forward permanently. So the easiest appliance and the first which was actually brought in orthodontics was an activator, which is simply acrylic as you can see, and you just make the patient bite in a forward position. That means you record the construction bite, make the appliance, and there is just one short label bow and upper. That's it. So it's the simplest of all. Then there were various modifications of activator which came in. Then there came another appliance which is also almost similar to activator. It is called bionator, which is less bulkier. So we have increased the wire components over here, but we have decreased the acrylic part over here. So it was to add more comfort to the patient. So this is how it exactly looks. Then you have your only tissue-borne myofunctional appliance, that is your Frankel's functional regulator. This is the appliance which is much more physiological than any other appliance because it does not touch the tooth anywhere. Okay. Then we have William Clark's twin block appliance. Twin block, that means it's available in two separate blocks. One is given in the upper, one is in the lower, and this inclined plane will make the patient bite in a forward position. Then later we realized that the compliance was a big factor. If we give removable appliances, then we switched over to our fixed functional appliances. So which one is this? Very, very flexible, just a spring. So this is your flexible fixed functional appliance. So that's your Jasper jumper. So the basic principles of all your myofunctional appliances are just two principles: force application and force elimination. So all the good forces it will let you apply, and it eliminates any unwanted restraining forces. So if you look at this, it all revolves around your buccinator mechanism. Your buccinator mechanism says that your teeth are actually in their current position because there is a balance between tongue inside, which is the strongest muscle, and the muscles outside, your orbicularis oris, buccinator. So the muscles inside and outside of the dentition have to be in a balance so that teeth do not move. So we can actually use this principle if we want the jawbone or teeth to move in a particular direction. So if you look at the Frankel appliance, that's how it's exactly working. So you have your lip pads, which is going to make the upper lip go away from maxilla. It will not let the upper lip touch the maxilla. So the restraining effect of the upper lip will go away. So it will let the maxilla grow. So that means this appliance I am going to give when I want the maxilla to grow. That means to somebody whose maxilla is retrognathic. That means I am going to give it in a class 3 patient whose maxilla is retrognathic, and this labial bow in the mandible is going to have a mild restraining effect on the mandibular dentition. Okay, same way, this is your again 1, 2 twin block. Okay, because this appliance is divided into two parts, we call it a twin block. Now this is acting more on force elimination. Frankel is acting more on force elimination, whereas your twin block is acting more on your force application. So it is going to, this appliance has to be worn while patient is eating also. So we assume when the patient eats, there is an inclined plane here. So all your occlusal forces are going to be directed in a mesial direction. So all force application is directed mesially. Hence your mandible also goes mesially. Functional matrix theory. If function is there, growth of the bone will be in the same direction. So the basic effects that we assume will happen in the mandible when we give a myofunctional appliance will be the condyle will growth, there will be reshaping, and also the glenoid fossa remodeling will be seen to accommodate the new condyle. And on the maxilla, this I am talking about the effects if given in class 2 patients. Okay, that means to grow the mandible, and we want the maxilla to go back, because mostly we are giving a myofunctional appliances for class 2 patients, only rarely for class 3. So in all the books, whatever effects you find, they are generally given for class 2 skeletal basis correction only. Okay, but of course there is going to be a reverse effect if you are giving an appliance for class 3 correction. Okay, so please don't get confused. These are all for, we are assuming a class 2 skeletal base correction. Okay, so the teeth are also going to move in the same direction as your jaw bones. However, this is a drawback of myofunctional appliance. Our myofunctional appliances are not supposed to move the teeth. They are supposed to move the jaw bones only. But still we will have this side effect. Of course, it will be minimum in your Frankel appliance, which is touching, at least the acrylic component is not touching the teeth anywhere. So what are the advantages of a functional appliance? Of course, there is less chairside time. You just have to view the patient and see if everything is okay. There are no ulcers every month, not that you have to do a wire change, limb braces. Okay, and of course, if a child is growing like this and I improve the jaw growth in the patient Muscular and skeletal disbalance improves at an early age. It gives a lot of psychological benefit to the growing individuals because they start looking good. It gives them a lot of confidence. And of course, you can easily remove the appliance and clean. Unlike your fixed appliances, these braces where it becomes a difficult job in maintaining oral hygiene. Of course, with fixed functional appliance, this drawback will be there with them as well, but compliance will not be required. So limitations are, if you have a class 3 patient in an adult, you cannot go for a myofunctional appliance. Remember, your myofunctional appliance can grow the mandible or redirect the maxillary growth only if growth is left. If no growth is left, then what is the only option left? It has to be a surgery. And of course, uncooperative patients, especially your removable myofunctional appliances, cannot be given. Then, if you have extreme crowding, that means you have dental problem, then you need braces. Remember, this appliance is not meant to move the teeth. So if you want the teeth to move, there is crowding and your concern is something else, then you need braces. Okay, probably if you have skeletal problem along with dental problem, then you go for your myofunctional appliance first, correct your jaw problem before the growth ceases, and then continue with your fixed mechanotherapy. Now, suppose you have a patient like this. If you look at the patient, she is class 2, maxilla in front, mandible behind, and that's her intraoral picture. So what's this incisor relationship called? It's a class 2 molar, and the incisor relationship is your retroclined upper incisors with labally tipped lateral incisors. So this is a typical class 2 division 2 incisor relationship. In such a case, I want to give her a functional appliance because she is growing and there is class 2 skeletal problem. So I want to give her a functional appliance. I make her bite in a forward direction. But if you see, there is no overjet. So how do I make her bite in a forward direction, and how do I make a myofunctional appliance for her? Even if I know she is class 2, I cannot make an appliance. There is no overjet to advance the mandible, even if the molar relationship is class 2. So in such cases, they need a pre-fixed mechanotherapy. That means you first have to put braces, get the overjet, and then you advance the mandible. And since braces are already there, you can actually go for a fixed functional appliance. So now just one appliance we're going to take up in this lecture. That's your Frankel functional regulator, which I already told you is the only tissue-borne myofunctional appliance, and it comes in group 3. Just for a recap, we have a small video here. So if you look at it, this is a class 2 patient and these are your lip pads. This is your lingual sheet and this is your buccal sheet. Okay, you make the patient wear this. So here the lip pads are in the mandible. So you want the restraining effect of the lower lip to be away from the mandible so that your mandible can grow freely, and you have a mild restraining effect of the maxillary labial bone to restrain your maxillary teeth or the maxilla to grow, which is of course going to be minimal. And hence you're going to convert a class 2 patient into a class 1. Okay, so I've already told you it works on your force elimination principle, Buck-Sinator mechanism, equilibrium theory. So basically we are going to alter the muscular forces acting on the buccal and the palatal side of your teeth and the jaw bones, and hence make the dentition move accordingly. So its main components are its acrylic components. If you see, you have your buccal shield, which is going to move away the restraining effect of the cheeks. So you can have a thicker buccal shield. If you want to grow the maxilla, you'll have a thicker shield here and thinner here. If you want to grow the mandible more, then you can have a thicker shield here and thinner here. So if you see, it's going to let the maxilla and the mandible grow transversely also. So your cross bites, scissor bites will also in turn get corrected. So it is going to cause a passive expansion also. Okay, then you have a lingual sheath inside. This is the sheath which will force the patient to bite in a forward direction basically. So you have your buccal shields which have to be deeply extended with a nice thickness so that it doesn't break, and it has to expand your orofacial capsule. So together with the lip pads, which should be teardrop shaped, not causing any ulcers here, and it will improve your posture. If there is any lip trap habit also, hyperactive mentalis activity, all that will be eliminated because your lip pad will come in between, so patient cannot suck the lip anymore. So I told you myofunctional appliances, that means muscle training, so it's going to train the muscles and grow your jaw bases. So together they are going to help you in improving your mandibular protrusion. Lingual sheath has got a very important role, that it is going to hurt the patient if the patient again forces and tries to bite in the old position. So the signal will be sent to the brain and patient will be reminded that no, he cannot bite there. He has to bite in a forward position. Otherwise, it will hurt in the lingual sulcus, this lingual sheath. So this is a reminder for the patient. So the various types of frankel appliances, so their types are actually numbered or named according to the malocclusion in which it is given. So a frankel 1 appliance will be given in class 1 malocclusion. So why would I give it in a class 1 malocclusion? High functional appliances are supposed to be for skeletal problem, right? So when I'm giving it in class 1, that means there is some muscular problem, or probably there is a deep bite. Deep bite means vertical skeletal problem can also be there. It need not be sagittal skeletal problem only, right? So a Frankel 1A will be given when there is a deep bite present. A Frankel 1B will be given when your overjet is there but it is less than 5 millimeters. That means it is still class 1 but the overjet is more and you want to reduce it by the growth of the jaw bones, not by moving the teeth. But when your overjet becomes more than 7 millimeters, then you give again 1C. Again, the patient is still not completely class 2. And this one has got a special feature that you can use the same appliance twice by cutting the acrylic in between and splitting and advancing the mandible again. Then you have FR2, which will be given for class 2 malocclusion, be it class 2 division 1 or division 2. Division 2 might need some modifications of proclining your upper incisors by a lingual spring there if you don't want to do a pre-fixed mechanotherapy and put braces. Okay, now FR3 or functional regulator 3 will be given in class 3 skeletal basis. So if you look at the structure, there is a minimal change. So patient is class 3 and here I want the patient's maxilla to grow. So in that case, I will have the lip pads in the maxilla, not in the mandible, because I want to keep the restraining effect of the upper lip away from the maxilla and the maxillary dentition, and I want to let the maxilla grow to its fullest possible potential. And instead, the labial bow is got transferred to the mandibular anteriors to have a mild restraining effect on the mandible. So that's how FR2 and FR3, the moment you look at them, you know the function for which it is given. Your position of lip pads and labial bows are opposite in both of them. So that's your FR3, same components but reverse position. You have your upper lip pads, lower labial wire. You also have occlusal rests there. What is the function of occlusal rests? There is an upper lingual wire because I want to procline, I want to take the entire maxilla in front. So anything which pushes my upper teeth out is in my favor. Okay, occlusal rests are basically given. Suppose I want to grow my mandible. In that case, I will let the mandibular posteriors erupt because whenever eruption happens, it happens vertically and mesially. So it grows the jawbone accordingly. So if I want the mandible to grow, I will not keep occlusal rest in mandibular posteriors, but I will keep occlusal rests on the maxillary posteriors because I don't want the maxilla to grow. Okay, and if I want the maxilla to grow, then I will keep the occlusal rests on mandible. Okay, so the same thing will happen in the type of appliances we are giving. Now we have a FR4 which will be given for open bite, again vertical problem, vertical skeletal problem, and I want to correct it. So here you have 4 occlusal rests. So why do you think we are having occlusal rests? We are having occlusal rests on the posteriors because you have to imagine if your we don't want the posteriors to erupt further. If my posteriors erupt further, the open bite will increase. If I can manage to intrude them instead, then my open bite will decrease. Okay. FR5 will be given if there is vertical maxillary excess. So here I have a frankel with a face bow attached, and I am going to attach on this face bow this elastic rubbers, and attach it on the head. So I am going to pull my maxilla up and behind. Okay, because maxilla is in excess vertically, so I want to pull it up, and also it is in front, so I'll put it up and behind. So such patients are the ones who will be coming with extreme gummy smile. Okay, so this is actually a combination of myofunctional appliances with your orthopedic appliance, where you are applying heavy force to redirect the jaw bones. This is your head gear. So this is a Frankel appliance combined with your head gear. So construction bite, in particularly for Frankel, the way I told you, you make the patient bite in a forward position. However, this person Frankel is a very physiological person. So you make the patient bite in a forward position, but he says he believes in a stepwise advancement only. That means you do not overcorrect and take it edge to edge. If the overjet is 10 mm, don't make the patient bite 10 mm forward. He believes in very physiological way of correcting the malocclusion, and he says you make two appliances. First you make the patient bite 4 mm in front, and then you make another appliance after 1 year, and you make the patient bite another 5 mm in front. So he's a very physiological person, and his philosophy, this is very important. If you look at the appliance, the first philosophy is he believes that everything has to work in the vestibule. So no acrylic component is really touching the teeth. So vestibular arena of operation. Periosteal pull by lip pads and buccal shields. So the lip pads here and the buccal shields are supposed to be going deep into the sulcus and pull the periosteum and help in bone growth. Minimal maxillary basal effect, that means minimal restraining effect which will be there of the maxilla because of the labial bow. Again, I'm talking about FR2. Okay. And if you look at the maxillary cast, this is how it looks. And sagittal correction via tooth-borne maxillary anchorage. So what does this mean? Sagittal correction. That means I'm going to correct a class 2 to become a class 1. So I don't want the maxillary teeth to erupt because I don't want to maxilla to grow. So I am going to have occlusal stops here on the maxillary teeth. But I will not have such stops on the mandibular teeth, because when the mandibular teeth erupt mesially and vertically, my mandible will also grow. Okay, so this is called your sagittal correction in sagittal plane from class 2 to class 1 via tooth-borne maxillary anchorage. That means your occlusal stops in the maxilla. In other words, it also means differential eruption guidance, where you allow the mandibular posteriors to erupt, however you inhibit the maxillary posteriors to erupt and help correct the jaw bases. So the treatment phases are divided into the initial phase, where you give the appliance to the patient, and first week you ask the patient to wear it just for 1 to 3 hours because it's something new you're giving to the patient, and let the patient be comfortable with it. Second week you increase it to about 4 to 6 hours, and then next 3 to 4 months it has to be worn full time. Of course, it has to be out of the mouth when the patient is eating. You cannot eat with it. Then you have your active phase, where the patient will be visiting you monthly, and you're going to check for any signs of ulcerations, because we expect the buccal shields and the lip pads to be very deep so that they can cause periosteal pull and bone formation. So it has to be monthly once, where you're just doing the checkup. And this retention phase will be once it's almost done, the correction is done, and you know when the appliance is out to the patient's mouth, then also patient is biting in a forward position and patient is actually become class 1, you will be able to change, you'll be able to appreciate the change. So it will be another 6 months for safety reason, and it's better to have it till growth is still remaining, otherwise the growth can go in the same direction as it was present previously. Hence the treatment duration actually will change depending upon what age the appliance was given to you and how much growth was left. Okay, then probably for retention you wear it for another 6 hours towards the end of the treatment, then next 1 year only night time. So I'm assuming this will be again different for different age groups, at what age it has been given to you. And of course, then if you still wish to correct the teeth, there is crowding, spacing. For your dental movement, you still need your braces or fixed appliance. So that's all from me. Thank you. Please let me know if you have any queries. Thank you.